I think it was in 1994 that I saw my first patient who had LAM. Since that time, I have seen about 5 or 6 other patients with the condition. I think that it needs to be borne in mind that my colleagues at Auckland Hospital tend to refer patients with LAM to me because they know that I have an interest in this condition. LAM is a rare lung disease, and in their professional lifetime, each respiratory physician is likely to see 1 or perhaps 2 patients with LAM. Over the last 20 years, there have been tremendous developments in this condition, both in terms of the understanding of the disease and in the treatment of the disease. In relation to both of those, I'd like to acknowledge the contribution of the LAM foundations in terms of their advocacy, their fundraising, their interaction with physicians and scientists. And the LAM foundations in New Zealand and the US and elsewhere have made tremendous contributions to our understanding of this disease. We now have a better understanding of the cells that cause this disease and the mechanisms by which those cells cause the manifestations of this disease in the lung. Perhaps most importantly, we now understand the subcellular mechanisms involved in this condition. In particular, the fact that this condition involves abnormalities in the so-called TOR pathway, TOR standing for target of rapamycin. Hence, it's no coincidence that rapamycin, also known as sirolimus, is now used in the treatment of this condition.
What are the important things that GPs would look at for LAM? What symptoms might they suddenly think, wow, wonder what this is?
LAM is a rare lung disease, and it's not feasible for general practitioners to know very much about LAM or to think of LAM on a daily basis. However, it's like the recognition of all rare diseases. You need to think about the possibility that this may not be a straightforward or common disease, and look out for things that are unusual or atypical. Most patients with LAM will be young or middle-aged women, and they will present with shortness of breath. The general practitioner will do spirometry, and that will show an obstructive pattern. And so the initial diagnosis might be that of asthma, but it will be unusual, and in particular will not respond typically to asthma therapy. Therefore, my advice is think about the young woman who presents with asthma. If their course is atypical, if their presentation is atypical, if they don't respond to asthma therapy in the way that they should, then those are the people that you would refer to a respiratory physician for another opinion. The other way that LAM can present is with a pneumothorax. So obviously a pneumothorax in a young, middle-aged woman, particularly recurrent pneumothoraces or pneumothoraces that affect both sides, either simultaneously or sequentially. That should raise a number of possibilities in the mind of the clinician, and one of those possibilities is LAM. LAM tends to be a progressive disease. However, there is great variation in the course of this disease. Unfortunately, in some women, it will be a rapid progression of disease and over a relatively short period of time, usually measured in a small number of years, they will have severe impairment of their exercise capacity, may become oxygen dependent, and then may need to be considered for the possibility of lung transplantation. With the greater access to CT scans, we now realise that there are quite a number of women who have LAM, who have mild disease, and in whom the progression of the disease is very slow indeed. So that just underlines the fact that when one makes a diagnosis of LAM, it is difficult to predict what is going to happen to that individual patient. LAM is monitored clinically, but also by repeat lung function tests. The features that we look for in the lung function tests is firstly evidence of airflow obstruction, particularly a reduction in the FEV1, a disproportionate reduction in FEV1 when compared with forced vital capacity. And also characteristically, there is evidence of hyperinflation of static lung volumes and also a reduction in the diffusing capacity, that is a low DLCO. In recent years, there have been tremendous advances in the management of LAM. And as a result of a number of important landmark studies, the drug sirolimus, also known as rapamycin, is now used for many women who have LAM. However, like all drug therapy, you have to balance the risks of the therapy against the benefits. And therefore, sometimes we will observe the woman after the diagnosis of LAM to determine whether or not their lung function is deteriorating over time, because the indication for sirolimus would be to slow that deterioration in lung function. Also to be considered are whether the patient has other manifestations of LAM, for example, the benign tumours that occur in the kidneys, because that too may be an indication for starting sirolimus therapy. Sirolimus therapy for LAM is usually begun by a respiratory specialist. Although the general practitioner can certainly provide ongoing supply of that drug, most women who have LAM and who are on treatment with sirolimus need regular review by a respiratory physician. Firstly, to supervise the treatment, to make sure that adverse effects are not occurring, but also to monitor the progression of the disease. And that requires consultation with the patient, examination of the patient, serial lung function testing, and sometimes repeat CT scans of the chest or imaging of any kidney tumours which may be present.
Given that sirolimus slows down the inevitable pace of LAM, what should GPs know about their patients who might be postmenopausal in this condition?
The question of what happens in LAM when the woman enters menopause is actually quite a difficult question to answer. We believe that estrogens seem to drive this condition. And in the past, there was a focus on anti-estrogen therapies for this condition, although I think that now has been superseded by the effectiveness of sirolimus. On that basis, we would expect that after menopause, the disease would stabilise or that the rate of progression of the disease would slow markedly. Several decades ago, the people who were diagnosed with LAM tended to be those with severe disease at presentation and who had a rapidly progressive course. it was recognised even in those days that estrogen seemed to drive the condition, and therefore the focus was on anti-estrogen therapies. This was the administration of progesterone or anti-estrogen therapies like tamoxifen, or even oophorectomy, the removal of the ovaries in these women. None of those therapies are currently used, and that relates to the effectiveness of sirolimus in many women who have this condition.